A very pleasant evening to all of you. Welcome to Nextopia Medical Lectures, and in this session we shall be discussing endocrine physiology, part 2 and part 3. All right, hope you have followed my lecture on part 1, which was including basics of endocrinology. From now on, we'll talk about each and every endocrine organ or endocrine system. To start with, we start with the most important organ system, which is a part of endocrine system of our body, and that is the hypothalamus and pituitary gland. Hypothalamus and pituitary again divided into anterior pituitary and posterior pituitary. So our main focus of discussion today will be these. All right, the hypothalamus pituitary axis, we'll talk about it. All right, in this I'll revise again what are all the basic concepts yesterday or the last class I discussed. Anterior pituitary. All right, there is a relationship between these two. Hypothalamus controls anterior pituitary and forms what is known as an axis, hypothalamo-pituitary axis. So we will be discussing the important aspects of this axis. If I am audible properly or not, please let me know so that I can change the settings. Am I visible or not? Is my teaching okay or not? Please let me know immediately so that I can change the settings, as it's a live class. So dear students, the hormone system, the entire hormone system, we talked about in our last class that it is divided into two types of hormones, the lipid soluble hormones and the water soluble hormones. So please remember that the hormones present in the hypothalamus and anterior pituitary gland, all these hormones are water soluble hormones. It's an important point. It means that the plasma transport of this water soluble hormone and storage, and we talk about all the differences yesterday, its action on the cell membrane and then internalization, then secondary messenger system, all that apply as a rule to all the hormones which are secreted by the hypothalamus and the anterior pituitary. So how is the hypothalamic hormones controlling the anterior pituitary? We'll try to understand. Please remember, hypothalamus itself is an important area of the brain which has got multiple nuclei. We call it anterior nucleus, posterior nucleus, medial nucleus, lateral nucleus. Sometimes we further classify it into ventromedian nucleus, posteromedian nucleus. All right, anterolateral nucleus, or we call it preoptic nucleus, paraventricular nucleus. So there are a number of names given to these nuclei. Each and every nucleus of the hypothalamus has got various functions. So this hypothalamus is nothing but a neuronal body or a cell body of the neuron. Lot of neurons, many neurons, multiple neurons are present in this hypothalamus. So please remember, hypothalamic hormones, where are they synthesized? Hypothalamic hormones, the hypothalamus related hypothalamic hormones are synthesized in the cell body of the hypothalamic neurons. Then after synthesis, once synthesis is done, after synthesis, is done, it is stored in the vesicles. Yesterday I told you how in my last class I told you how the water soluble hormones are stored. They are not synthesized then and there as in case of lipid soluble hormones. They have to be synthesized separately and stored in the vesicles. They are packaged into the vesicle, then they are transported from the hypothalamus, from the cell body of the hypothalamus, they are transported to the axons. In the axons they are stored and they are released in the nerve terminals. From here they get transported to axons, and from here they move down to the nerve terminal. This is all occurring in the cell bodies or the neurons of the hypothalamus. We make it clear. Now, where is the pituitary located? Pituitary is located in a bony prominence, bony depression of the skull called as sella turcica. This sella turcica lodges the pituitary. It is present in the base of the skull. It hangs exactly from the hypothalamus with the help of a stalk. So say suppose this is the hypothalamus. It has got a stalk, and this is the pituitary gland, and here we have got the base of the skull, and this is the sella turcica. All right, there is one thin layer of membrane which is covering this part of sella turcica, this area of the sella turcica. This is the dura mater, which forms the roof of the sella turcica, which forms the roof of the sella turcica. It's a very important point. We need to understand this dura mater or dura membrane. It is forming a roof on the sella turcica. It has got a small fenestration through which the stalk holds the pituitary gland, and this stalk is connected to the hypothalamus. I'll label all the structures here. So this is the hypothalamus. This is the stalk, and this is the pituitary gland. This is the pituitary gland, if I am clear. All right, hope I am clear. So the main important point is this dura membrane or the dura mater. So this is the roof of the sella turcica, is it not? It is separating the overlying brain tissue from the pituitary gland, which is underlying the inside the depression of this bone called as sella turcica. Hence what happening is the CSF, the cerebrospinal fluid, it is prevented from entering into the sella turcica. It's a very important point. Hence CSF related diseases like increased intracranial hypertension, increased pressure inside the cranial cavity, intracranial hypertension, or sometimes CSF infections like meningitis cannot spread to the pituitary gland, and pituitary is spared usually from these CSF related diseases thanks to the diaphragm or the sella turcica. Just above this diaphragm, we have got one more important structure here running above the diaphragm, 5 to 10 mm above, and this is like an X, like this. This is one limb of that X. This is the another limb of that X. Because it is in the form of X, you are calling it as a chiasm. The optic chiasm or optic chiasma. The optic chiasma is nothing but a part of the optic nerve which crosses the both sides, that is right and left optic nerve crossing occurs exactly above the pituitary gland, and it forms what is known as optic chiasm or optic chiasma. This is lying 5 to 10 millimeters above the diaphragm. All right, hence you can understand how important this area is, and it has got the hypothalamo-pituitary portal system of blood flow. There is a small portal system of blood vessels, very little tiny blood vessels that supply both to the hypothalamus and the pituitary gland. Continuously the supply is in between these two organs. Whenever there is an exchange of blood in between two organs, we call it a portal system. So we have got portal system called as hypothalamo-hypophyseal. Pituitary also called as hypophysis cerebri. The another name for pituitary gland is hypophysis cerebri. Hypophysis. So hypothalamus, that is a structure that is lying below the thalamus. Hypophysis, that is the structure that is lying below the optic chiasm or the stalk or the infundibulum. You call it hypophysis cerebri. So this is the pituitary gland. So we have got a portal system between a hypothalamus and the hypophysis. We call it hypothalamo-hypophyseal portal system, which obviously carries the hormones from the hypothalamus. These hormones from the hypothalamus control the hormones of the pituitary gland. So what happens is that hypothalamus controls the pituitary gland controls the further end organ, target organs or end organ. For example, hypothalamus releases thyrotropin hormone, thyrotropin or TSH releasing hormone, thyrotropin releasing hormone, TRH. Whereas this TRH crosses from the hypothalamus, it goes to the anterior pituitary. It stimulates the release of TSH, thyroid stimulating hormone. This TSH comes down and stimulates the thyroid gland present in front of your neck to release T3 and T4. So this is how we'll discuss each and every hormone in detail shortly. Just I'm giving you an example. Apart from this, the release of the hormones from the hypothalamus anterior pituitary system, it is pulsatile in nature. Yesterday I told you I was talking about the release, either continuous release or pulsatile release. It's not two options. So we have got pulsatile release. Why nature has created pulsatile release of the organs, of the hormones, is that, please remember that whenever there is a continuous release, the organ cannot be stimulated enough. Whenever there is a continuous release, say suppose one constant level of release of the hormone is occurring, it cannot stimulate the gland further to release more in a fashion of increase or decrease. So the stimulation also will be continuous, release also will be continuous. So pulsatile release actually makes sure that certain hormones increase, decrease whenever you require it, whenever you want it. For example, in one phase of menstrual cycle, I'll discuss this in detail when I'll be talking about the ovaries. But again, a small hint I would like to give you, like GnRH hormone. The gonadotropin releasing hormone is a classical example of pulsatile release. This helps in the variations in the release of LH and FSH. Variations in the release of LH and FSH thanks to the pulsatile fashion release from the hypothalamus and the anterior pituitary and the pituitary gland as a whole. All right. So let us now summarize anterior pituitary and hypothalamus relationship in a nutshell. Again, with the help of a simple diagram. For example, this area is hypothalamus and it has got a stalk or an infundibulum, and below it we have got the anterior and the posterior pituitary gland. For example, the nucleus of the hypothalamus, for example, we talk about the preoptic nucleus somewhere here. Say suppose it's a preoptic nucleus. Preoptic nucleus is secreting what? Preoptic nucleus is secreting the gonadotropin releasing hormone, which is acting on the pituitary gland, which is acting on the various organs of our target organs of the body to release FSH and LH. Similarly, we have got ventromedial nucleus somewhere here. Ventromedial nucleus of the hypothalamus. All right. We have got arcuate nucleus somewhere here. The arcuate nucleus of the hypothalamus. Arcuate nucleus of the hypothalamus releasing the dopamine and gonadotropin releasing hormone. All right. Via the hypophyseal portal system, all these hormones are, say suppose we have got another nucleus called as paraventricular nucleus. Paraventricular nucleus, which is responsible for the release of the corticotropin releasing hormone, the somatostatin, and the thyrotropin releasing hormone, TSH releasing hormone. All right. All these hormones, they act on the pituitary gland and they stimulate the pituitary gland to release the stimulating hormones. All right. Stimulating hormones. The nerve endings of the hypothalamus, they come together in the medial eminence region of the hypothalamus and the hormones are secreted. These hormones are stored into the vesicles. Vesicles are getting transported. The hormone gets transported across the organs to the nerve terminals. From there, they enter into the hypophyseal portal system, and then from the portal system, small, little microscopic blood flow. It crosses the pituitary gland. It enters the pituitary gland and stimulates the anterior pituitary. The hypothalamic hormones, they bind to the receptors And where are these receptors present, inside the cell or outside the cell? Because it's a water soluble hormone, the receptors are present outside the cell, I told you, and outside the cell, external receptors of the anterior pituitary, and they modify the secretion. They stimulate the anterior pituitary to release the TSH. They stimulate the anterior pituitary to release the TSH. They stimulate the anterior pituitary to release the growth hormone. They stimulate the anterior pituitary to release the FSH. They stimulate the anterior pituitary to release the corticotropin, that is ACTH, the prolactin, the LH. All these hormones are released by the anterior pituitary thanks to the hypothalamic stimulation. Now let us try to understand how, specifically let us try to understand how the TSH, the ACTH and various other hormones are getting stimulated with the help of this flowchart. Alright, the TSH is under the control of thyrotropin releasing hormone. Thyrotropin releasing hormone from the hypothalamus. From the hypothalamus, thyrotropin releasing hormone, it acts on the thyrotropes and it results in production of TSH. Where is this TSH acting? TSH acts on the thyroid gland to cause release of T3 and T4 on the thyroid gland. Just an example. I'm not going further detail into it. We'll discuss that this is a separate chapter. Similarly, growth hormone. The growth hormone is under the control of somatostatin, SST, somatostatin. Somatostatin is released from the pituitary. The GnRH, gonadotropin releasing hormone, also stimulates the growth hormone. Somatostatin also stimulates the growth hormone. And growth hormone cells are actually 50% of the anterior pituitary. Is it not an important point to remember? Because entire pituitary, most of the pituitary gland, majority cells in the pituitary gland are somatotropes or growth hormone releasing cells. We call it somatotropes. Somatotrophs. So most of the pituitary gland is made up of somatotropes. So if I ask you which is the most common disease of the anterior pituitary gland, obviously the cell which is much more common in number, definitely that is the first cell which is going to get destroyed or which is going to face the brunt of the disease. Hence, growth hormone disorders are very common in case of anterior pituitary disorders. Manifestation of the growth hormone is very common. Next comes the ACTH. How is the ACTH stimulated? It is by corticotropin releasing hormone. Corticotropin. How is the FSH stimulated? The GnRH stimulates the FSH. How is the prolactin stimulated? Prolactin, it has got an important correlation with dopamine. It's a very important point. Please note it down because you will understand this concept here itself. The diseases of the prolactin causing prolactinoma. There are certain cells called as lactotropes in the pituitary gland which account around 10 to 15% of the pituitary gland, and they are under the influence of the dopamine. Dopamine causes inhibition of the lactotropes, whereas the TRH causes stimulation of the prolactin. Dopamine causes inhibition, whereas TRH causes stimulation of the prolactin. Please remember this point. Alright, then LH is under the influence of GnRH. LH is under the influence of GnRH. Alright, all these points, please remember. Very high frequencies of LH and low frequencies are in favor of FSH. Alright. So, having understood the mechanisms, having understood the basic physiology of what stimulates which part of the pituitary gland, let us try to understand the disorders of the hypothalamus anterior pituitary axis. Let us try to understand the disorders. In case of the disorders, please remember, we'll discuss it as hypopituitarism first. Alright, then we'll discuss about the diseases of, that is in the neoplastic disorders, that is the that is the neoplasms of the pituitary gland. So first we'll discuss hypopituitarism. Hypopituitarism. The hypopituitarism is nothing but it is the deficiency or decreased function of the pituitary gland, obviously. The causes, major causes are head trauma, closed head trauma. It's a very important cause. Many people ignore it. Closed head trauma is the most important cause. Sometimes mass effect, some tumor in the brain is causing mass effect. Mass effect. All right. Sometimes infection or inflammation. All right. Sometimes vascular injury. Sometimes vascular injury. Please remember. So what's happening in hypopituitarism is there is a sequential loss of function. The name itself is telling loss of function. So loss of function of what? Loss of function of growth hormone. So there is decrease in the growth hormone function. There is fall in the gonadotropins function. Then decreased TSH. Then decreased ACTH. All these functions are lost, and finally the last one to get affected is the prolactin. If patient presents with prolactin related clinical signs and symptoms, it means the disease is very much advanced. I'll discuss all these details shortly from now, how to identify clinically and all. But first important point to understand is there any isolated deficiency? Is there any out of all these will hypopituitarism or pan-hypopituitarism we call it, all the hormones are losing their function. There is sequential loss of function of all these hormones. Sometimes there is isolated deficiency. Isolated deficiency means what? Each and every hormone itself can suddenly become deficient and it can manifest. So amongst the isolated deficiency, growth hormone is a classical example for isolated deficiency. Isolated deficiency of growth hormone is a classical example. Isolated deficiency of growth hormone is a classical example. Here, so if the disorder occurs in childhood, the person becomes dwarf. All right. Usually the manifestation occurs in children. Growth hormone deficiency manifestations are common in children. Apart from this, the gonadotropin isolated deficiencies. We are discussing isolated deficiencies or individual deficiencies. So the gonadotropin isolated deficiencies or individual deficiencies manifested in Kallmann syndrome. In Kallmann syndrome, there is a defective synthesis of GnRH. GnRH synthesis disorder. Disorder of synthesis of GnRH. Further, this causes reduction in the LH, reduction in the FSH, and reduction in the sex steroids. Sex steroids. LH, FSH, and sex steroids. All right. Sometimes isolated deficiency of prolactin can occur, TSH can occur, ACTH can occur, which are very, very rare actually. And if it is present, it's a sign of pan-hypopituitarism, I already told you. Apart from this, in children, if you talk about, in children, which is the most common tumor of brain, in children, the most common tumor of brain is craniopharyngioma, and this craniopharyngioma is affecting the hypothalamus pituitary axis. Craniopharyngioma it affects the hypothalamus pituitary axis. Please remember this point. All right. Sometimes in pregnancy, what happens is there is postpartum hemorrhage, sudden loss of blood from the body in the form of uncontrolled uterine bleeding following delivery. What happens is in pregnancy, usually the pituitary is very much enlarged and it is receiving a lot of blood supply. Its blood supply is increased. So it is much more dependent on blood supply in pregnancy than in non-pregnant state. So immediately following delivery, if there is a severe blood loss, slightest amount of even 10% loss of blood also can cause shock in the patient. Once the patient develops shock, because of shock, what happens is physiologically shock will cause arteriolar constriction to increase the peripheral resistance. This is a physiological mechanism. And this arteriolar constriction can result in vascular damage to the pituitary gland. Vascular damage to the pituitary gland, causing the pituitary ischemia and pituitary necrosis. Ischemia and necrosis. Right? Hope you are able to understand this. So this is termed as, what is this syndrome termed as? In postpartum hemorrhage, postpartum pituitary necrosis. Postpartum pituitary necrosis is called as Sheehan's syndrome. Sheehan's syndrome. It's a very, very important question. All right. So this pituitary damage is secondary to the vascular, loss of blood supply because of shock. How does it manifest? Symptoms vary. Actually, person is in shock, then obviously you can expect, patient is not able to respond to your verbal command. Sometimes, it is very difficult to diagnose. But if patient is able to respond to your verbal command and the shock was very mild, if the failure to lactate, if the lady is unable to lactate for days following birth, it's an important sign of pituitary damage, and you should start investigating this case with the help of an MRI so that you understand the disease very quickly, so that you can at least intervene by replacing the hormones, because the growth hormone, the ACTH and all, ACTH actually, it's a essential hormone for life, is it not? And needs to be replaced. All right. Then these are all the hypopituitarism disorders. Next, we'll discuss the pituitary adenomas. Pituitary adenomas are a group of neoplasms, a disorder of the pituitary gland. Anterior pituitary adenomas are very, very common. The hypothalamo-anterior pituitary axis dysfunction occurs. There are two types of adenomas, microadenoma and macroadenoma. In this, microadenoma is very, very common. Microadenoma is defined as less than 1 centimeter in diameter. Less than 1 centimeter in diameter, and it is characterized by hormonal excess. There is no panhypopituitarism, and it's a disorder which is treatable. All right, three important points you need to remember. There is hormonal excess, there is no panhypopituitarism, and the disorder is treatable. Pituitary adenoma can manifest as hypogonadism. This is the second important point. Hypogonadism. In fact, hypogonadism is considered as the most common manifestation of pituitary adenoma. Hypogonadism is considered as the most common manifestation of the anterior pituitary adenoma. Most of the times these pituitary tumors are benign in nature, and sometimes they can autonomously, suddenly they can start secreting, causing hyperprolactinemia, increase in growth hormone causing acromegaly, and ACTH causing Cushing's disease. Yesterday I told you Cushing's syndrome and Cushing's disease difference I told you. So Cushing's disease here, because ACTH secretion may increase. Prolactinomas associated with hypogonadism and galactorrhea. Whereas pituitary adenomas, yesterday I told you about Men's syndrome. MEN 2A, MEN 2B, MEN 1. Yesterday I told you. So this is all about the MEN syndromes yesterday I was talking about, is it not? The MEN 1, which includes the hyperparathyroidism, pituitary adenomas, and endocrine pancreas tumors. Alright, so MEN 1 is very commonly associated in case of pituitary adenomas. This is what is an important point. Please make it sure that you remember this point. Alright. Yes. So there are two types of adenomas, microadenomas, and second is macroadenoma. Macroadenoma is defined as what? Macroadenoma means what? Macroadenoma of the pituitary gland means it is more than 1 centimeter in size. Macroadenomas, the name itself is indicating because it is large, it will cause mass effect or pressure effect on the adjacent normal tissue. They are large tumors. Sometimes supracellular extension occurs and they are associated with panhypopituitarism. Is microadenoma associated with panhypopituitarism? No. Whereas macroadenoma is associated with panhypopituitarism. Panhypopituitarism is present. Hypersecretion is a disorder that is associated with microadenoma. Hyposecretion is a disorder associated with macroadenoma. Name is big, but it does not secrete anything. Because it is extending above the sella turcica, it is crossing that dura mater membrane, which is protecting the pituitary gland roof. What is present above the roof? We have got optic chiasm. So this patient may present with disorders of optic chiasm compression causing visual loss. Loss of vision might be a manifestation of macroadenoma. Loss of vision might be a manifestation of macroadenoma. So this completes the part 2 of endocrine physiology, wherein we are discussing hypothalamus and anterior pituitary. Now time has come, let us discuss the part 3 of endocrine physiology. In this one video only we'll discuss part 2 and part 3 both. So part 3 of endocrine physiology, we'll discuss posterior pituitary. So let us discuss the posterior pituitary hormone physiology first, then we'll try to understand the disorders of the posterior pituitary gland. The hormones of the posterior pituitary, they are made up of they are concentrated in the distal neurons, distal neuron terminals. The important hormones are secreted by the posterior pituitary are the vasopressin. These are very essential hormones, important hormones. Vasopressin, which creates pressure on the blood vessels or causes vasoconstriction, so that we don't lose urine. Antidiuresis hormone, antidiuretic hormone, prevents the urine loss, prevents the water loss from the body in the form of urine. Next is the oxytocin, vasopressin and the oxytocin. Both of these are peptide hormones or water soluble hormones. They are secreted in the cell bodies or the neurons of supraoptic and paraventricular nucleus. Supraoptic and paraventricular nuclei of the hypothalamus. We know that hypothalamus is a important structure which secretes these hormones, and posterior pituitary only stores the hormones. Posterior pituitary does not secrete any hormone, it stores the hormones. The arginine vasopressin, the AVP or ADH, both are same. the new name given for ADH is AVP, arginine. Arginine is a protein peptide, amino acid. Arginine vasopressin and oxytocin. Please remember, the arginine vasopressin or the antidiuretic hormone is an important controller of water excretion from the body. It prevents the water excretion from the body. It is important regulator of the concentration of the plasma in the form of plasma osmolarity. Extracellular plasma osmolarity also is controlled by ADH. Alright. How is it controlling? It is controlling with the help of osmoreceptors. Osmoreceptor neurons are present in the hypothalamus. They are highly sensitive to any changes in the ECF osmolality. So the osmoreceptors present in the hypothalamus, these receptors are present in the neurons of the hypothalamus. They are highly sensitive to detect the changes in the ECF osmolarity. ECF osmolarity. The ECF osmolarity, even slightest change in the ECF osmolarity is detected by these neurons, so that release of ADH occurs, and it acts on the kidneys to prevent the diuresis. Or if ECF osmolarity is low, we tend to excrete more water, so that again the osmolarity becomes more concentrated. So in technical terms, if I can call it downward shift. There is a downward shift of plasma osmolarity, especially during pregnancy, during the menstrual cycle, and during the volume depletion state. So 3 important stages. Whenever you are water deprived, or volume depletion, or dehydration, whenever you are pregnant, I'm talking about the ladies who are pregnant. So during pregnancy, during water deprivation, and during menstrual cycle, every month, during the menstrual cycle, during the menstruation phase of the menstrual cycle, especially the bleeding phase of the menstrual cycle, that is not actually bleeding, it's a misnomer. I'll discuss that later on in my further classes. So in a water deprived state is the first example, pregnancy is the second example, menstruation is the third example. In all these 3 states, what's happening to the ADH? There is a downward shift of the plasma osmolarity. Plasma osmolarity downward shift occurs, and there is osmoregulation starts. Secondary to this osmoregulation starts, and it affects the circulating volume, it affects the circulating plasma volume, and it affects the plasma osmolarity. Alright, to further understand this, we need to understand that there are certain receptors called as volume receptors. Volume receptors which detect the volume. Pressure receptors, osmoreceptors which detect the osmolarity. We have got similarly volume receptors. Now volume receptors are less sensitive to changes in the volume. Volume receptors are less sensitive. They are not as sensitive as osmoreceptors. Volume receptors are less sensitive. Volume receptors, any change in the volume by 10 to 15% is detected. Any change in the volume, plasma volume of 10 to 15% is considered as a measurable change or a detectable change to change the ADH secretion. Apart from this, ADH is also controlled by angiotensin. The angiotensin 2 and the corticotropin releasing hormone. So there are 4 important aspects: the osmoreceptors, the volume receptors, the angiotensin 2, and the CRH. Angiotensin 2 and the CRH, the corticotropin releasing hormone. The angiotensin 2 and the CRH, they can stimulate the release of ADH. They have positive effect on the release of ADH. They can directly stimulate the release of ADH, so that diuresis is prevented, urine is prevented. Let's try to understand the neurohumoral regulation or neuronal control to regulate ADH from the posterior pituitary gland. Remember, the principal inputs that come They are in the form of inhibition from the baroreceptors, the cardiopulmonary receptors. Last in my cardiology class, pulmonology classes of physiology, I told you how the cardiopulmonary mechanoreceptors are detecting the changes in the carbon dioxide. They are detecting the changes in the partial pressure of carbon dioxide, partial pressure of oxygen, and they are getting stimulated. So these are the important regulatory mechanisms which are also acting on the ADH. So please remember what's happening in the atria. So in the heart, this is your heart. In the carotid body, this is the, say suppose the carotid body. So this is the carotids. These are the carotid body, and atria and ventricles. What happens is there are presence of stretch receptors. Stretch receptors are present, which act on the atria ventricle, which are present in the atria ventricle carotid body, and these are responsive to fall in the volume, any decrease in the volume, any decrease or increase in the volume, decrease or increase in the afferent activity, decrease or increase in the ADH. So via the volume or ADH or via the afferent activity, these stress receptors from the atria and the ventricle, they stimulate the hypothalamus. They stimulate the hypothalamus. So afferents are carried via the 9th nerve and the 10th nerve, the glossopharyngeal nerve and the vagus nerve, from the carotid body, from the atria, the large veins like superior vena cava, inferior vena cava. The afferents from these areas, stretch receptors are present, which carry the information to the hypothalamus. Hypothalamus causes release of ADH. It causes release of ADH from the posterior pituitary into the posterior pituitary, stored in the posterior pituitary. Stored in the posterior pituitary, and release of the hormone from the posterior pituitary. Now this posterior pituitary acts on this ADH comes out of the posterior pituitary circulation into the blood, and it acts on the kidneys. It acts on the kidneys. Where in the kidneys? In the nephrons. Where in the nephrons? If you remember my last class, in the renal collecting ducts. If you remember my class on nephrology, basics of nephrology, physiology, in that class I told you that the collecting ducts are the place where ADH acts, antidiuretic hormone acts. What is the function of antidiuretic hormone? It increases the permeability of renal collecting duct. Water is reabsorbed passively. Water reabsorption occurs passively. So whenever there is stimulation of ADH, antidiuresis, that is reabsorption of water, increases it. There is increased reabsorption of water. This point you will have to remember always. So what's happening? Because the ADH is acting on the collecting duct to cause increased reabsorption of water. Along with water, what is passively reabsorbed? The urea. Reabsorption of water and urea. This reabsorption of water and urea causes the plasma osmolarity to increase from 300 to 1200 osmoles. I mean the renal osmolarity, all right? The renal osmolarity increases from, so there is a lot of difference between the osmolarity only thanks to the reabsorption of water and urea. Reabsorption of water, H2O means water, and urea. And this is occurring in the collecting duct. It is under the influence of the ADH. Synthesis and release of ADH and action of ADH, we will try to understand it again. So where is the ADH synthesized? ADH is synthesized in the supraoptic and the paraventricular nuclei of the hypothalamus. I told you it is stored in the posterior pituitary. Whenever there is stimulation of the osmoreceptors or volume receptors or angiotensin 2 or CRH, osmoreceptors are the neurons which respond to the plasma osmolarity. So they actually detect the osmolarity with the help of plasma sodium concentration. So ADH osmoreceptors, which are present in the hypothalamus, how are they acting? They are acting actually to changes of the plasma sodium concentration. Sodium, because the sodium entering into your body actually determining whether to urinate or not. Sodium concentration, plasma sodium concentration. So these osmoreceptors, they depend on the plasma sodium concentration. They detect the plasma sodium concentration, especially present in the supraoptic and a paraventricular nucleus. Whenever there is increased plasma sodium concentration, it causes release of, it secretes ADH from the posterior pituitary gland. They also stimulate the consumption of water through the hypothalamus thirst receptor. So osmoreceptors are connected to the thirst receptors. You suddenly start feeling thirsty, and thirst receptors are stimulated, resulting in increased water intake. And especially this is occurring via the supraoptic and paraventricular nucleus. Supraoptic paraventricular nucleus, I already told you, they receive also inputs from the atria of your heart, from the large blood vessels, the veins, that is the superior and inferior vena cava. And any high blood volume or any high blood pressure, it inhibits the secretion of ADH. So increase in blood pressure, increase in blood volume, it causes a negative feedback mechanism, and it decreases the ADH secretion. Please remember, ADH secretion is highly sensitive to the plasma osmolarity. It also depends on the volume, but volume detection, at least 10 to 15% significant reduction in the volume only tends to release the ADH. Not less than 10% loss of blood volume will not stimulate ADH secretion. Whenever the person suffers from shock, say suppose trauma or shock, loss of blood volume, suddenly person loses blood, increase of ADH secretion occurs, and it may cause abnormal plasma, even whatever may be the, irrespective of the plasma osmolarity. If volume depletion is very high, it causes stimulation of ADH secretion. How does the ADH act? ADH acts on the collecting duct of the nephrons. I told you it acts on the collecting duct of the nephron with the help of V2 receptors, vasopressin 2 receptors, V2 receptors. It acts on the collecting duct of the nephron with the help of V2 receptors. The ADH, it increases the permeability to water and urea. It increases the permeability to water and the urea by placing the channels called as aquaporins. These are the water channels. They are present in the collecting duct of the nephron, collecting ducts of the nephron, and it is increased by the ADH, which is acting on the V2 receptors present on the collecting duct. This, what is the role of this aquaporin? The role of this aquaporin is to reabsorb water, increased water reabsorption. Increased water reabsorption across the luminal membrane. Via the V1 receptors, another receptor, the V1, there are two receptors, V2 receptor and V1 receptor. So V2 receptor present in the kidneys. V1 receptors, it causes vasoconstriction. So V1 receptor, it causes vasoconstriction. ADH act on the V1 receptors to cause vasoconstriction of the vascular smooth muscle. V2 receptors, it is acting on the renal tubules and causing the reabsorption of water and obviously of the urea. Now, the most important aspect of the video has come in now. If you want to take a break, stop the video, go for a break and come back, because from here we need to understand the concepts of ADH osmoregulation, volume regulation, plasma osmolarity, ECF osmolarity, which is very important to understand now, right? So let us continue. Right. Let us try to understand the regulation of the ECF volume and the volume and the osmolarity. volume and the osmolarity. Let us try to understand. The osmoregulation with the help of osmoreceptors, the volume regulation with the help of volume receptors, I already told you, but let us try to further understand how is this regulating the ECF volume and osmolarity. So the osmoregulation, any increase or decrease or any change in the osmolarity is immediately detected with the help of osmoreceptors, I told you, and we are very sensitive to detect any small change. For example, if there is only 1% change in osmoregulation, osmolarity, say suppose there is increase of osmolarity by 1%. By 1%. The ECF which is present near the osmoreceptors, the hypothalamus osmoreceptors, it increases the ADH secretion. It increases the ADH secretion. Say suppose there is decrease in the osmolarity. It decreases the ADH secretion. See how important it is. It decreases the ADH secretion. Our major aim is to maintain the plasma osmolarity between around 285 milliosmoles per kg. This is normal. Alright, this is what is the most important aspect of osmoregulation. Next, we'll try to understand the volume regulation. Any stimulation of stress receptors present in the heart, present in the carotid bodies, present in the large blood vessels, they actually act to inhibit ADH secretion. If you talk about the volume regulation, so volume regulation, how is it? So stress receptors, their basic aim is to inhibit or decrease ADH secretion. Any decrease in the blood volume, say suppose blood loss can cause again stress receptor stimulation to send less signals to CNS, means there is decreased inhibition of ADH or indirectly increase in the secretion of ADH. Alright, so this mechanism is especially important in case of hemorrhage or road traffic accidents. Sudden hemorrhage occurs. This mechanism, the volume regulation mechanism, is most important. So please remember, stimulation of stress receptors. Whenever there is stimulation of stress receptors, there is feedback inhibition of ADH. Less stimulation of stress receptors, less inhibition of ADH. It means increase in the ADH and causes volume correction, alright, or ECF correction. Alright. There are certain natriuretic peptides. Now these natriuretic peptides are present in the heart, hormones present in the heart. These hormones present in the heart, especially the right atrium, the ventricle, they are actually responding to the stretch or the volume related, blood volume related, or the stroke volume related stretch in the atria or the ventricle, and it may be increased in cases of CHF, in cases of congestive heart failure, fluid overload states, alright, or certain diseases of the heart and kidney, and it helps us to understand various diseases. So we'll talk about these natriuretic peptides now. Natri means sodium, uretic means, uresis means to cause urinate or to excrete the sodium. Natriuretic peptides. Alright. If it is from the atria, you call it ANP, atrial natriuretic peptide. We have got another type called as BNP, brain natriuretic peptide. The circulating levels of BNP correlate with the size of the heart. More size of the heart, dilation of the heart. For example, dilated cardiomyopathy, BNP increases. The plasma BNP levels are helping us to understand and diagnose the severity of the heart failure. So we've got ANP, BNP. It helps us to diagnose the severity of the heart failure. Nowadays, you are doing tests for ANP, BNP levels. If BNP levels are increased, person presenting with shock, and BNP levels are increased, it means that person is suffering from the dilated cardiomyopathy, and you can give certain drugs which causes inhibition of inhibition of inhibitors of BNP. Actually, BNP is helping in sodium loss. Natriuresis, it is causing natriuresis means what? It is helping in sodium loss and water loss, and thereby it causes the decrease in the plasma volume, and it may increase the glomerular filtration rate and helps in relieving the symptoms of heart failure. Hence, any drug which is looking like recombinant BNP, recombinant ANP, or inhibitor of inhibitors of ANP and BNP can be used as drugs. I'll discuss this in pharmacology in detail. So basically, what is the function of ANP and how is it secreted? The ANP hormone is secreted in the right atrium. This point, please remember, right atrium. This ANP hormone stimulates any stimulus causes release of ANP from the right atrium. The important stimuli to release are, one is stretch. Stretch is an important stimulus. Then another stimulus is CHF, congestive heart failure. Another stimulus is volume overload. Any form of volume overload. You give lots of IV fluids to the patient, his ANP levels will increase. It causes sodium loss. So what is the function of ANP? The function of ANP is causes sodium loss and water loss, water excretion or loss. From where? From the kidneys. From the kidneys. Hence, it increases the glomerular filtration rate. Please remember that the ANP mediated, what happens is in the nephron, if you remember, in my class of nephron, if you remember, so this is the glomerular, this is the Bowman's cup, this is the afferent renal arteriole. If you remember my class, nephrology, this is the glomerulus, this is the efferent renal arteriole. E stands for efferent renal arteriole, A stands for afferent renal. What is the function of ANP? What is the action of ANP on this nephron? On the afferent renal arteriole, the ANP causes vasodilation. ANP causes vasodilation. So more and more blood is reaching the glomerulus. Whereas on the efferent renal arteriole, it causes vasoconstriction. So the inlet, it is causing dilation. The outlet, it is causing constriction. What will happen to the GFR? What will happen to the GFR? Increased, increased, and increased, thanks to the action mediated by the ANP. All right. ANP also inhibits the renin-aldosterone axis. The renin-angiotensin-aldosterone axis. Hence, again, if you inhibit aldosterone, what happens? Sodium and water reabsorption is inhibited. Potassium and H plus excretion is inhibited. If reabsorption is inhibited, excretion is increased. And hence, it plays a major role in the normal regulation of ECF osmolarity and maintaining the urine osmolarity also. What are the additional points about ANP you need to understand? Additional point about ANP you need to understand is, in a normal heart, very little amount of BNP, the brain nitrate peptide, very little amount of BNP is secreted in a normal heart. And BNP has got same effect, same physiological effects as ANP. Both are vasoactive peptides, both are hormones. If the heart dilates, example heart failure, both the ANP and BNP levels are markedly increased. They are very much increased whenever the heart dilates because of stretch receptor. I told you stretch is a stimulus for release of ANP and BNP. In that, BNP is very, for example, dilated cardiomyopathy, cardiac fibrosis, or sometimes hypertrophy, systolic heart failure. All these cause vasodilation of the arterioles. BNP levels are increased, it causes vasodilation and tends to reduce the blood pressure. Please remember that the ANP and BNP, these are metabolized by an enzyme called as neprilysin. They are inhibited by an enzyme called as neprilysin. 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 Neprilysin is not selective for these peptides and it can cause breakdown of angiotensin 2 also. It can cause breakdown of bradykinin also. So we have got a drug called as sacubitril. which is a neprilysin inhibitor, which is an inhibitor of neprilysin. If it's an inhibitor of neprilysin, it is promoting the ANP and BNP, is it not? But what is the additional effect of neprilysin? It inhibits, neprilysin causes breakdown of ANP, BNP. Neprilysin also causes angiotensin 2 breakdown, is it not? Neprilysin also causes breakdown of bradykinin, is it not? So what you can do is you can make a combination of the neprilysin is actually, it is breaking down angiotensin 2 and it is increasing the angiotensin. You can make a combination of this along with the sacubitril. You can add valsartan, the angiotensin receptor blocker. This combination is approved by the FDA for the treatment of heart failure. The sacubitril valsartan combination. I'll discuss this in pharmacology. I'll discuss pharmacology in detail. It is helping. A lot of studies have proved that it is helping in improving the mortality. It has got mortality benefit in case of systolic heart failure. Patient with heart failure with normal or preserved ejection fraction, heart failure with preserved ejection fraction. It's a very wonderful drug and helping us in improving the mortality. Mortality benefit is present. All right. So this is all about the natriuretic peptides. Next topic of discussion is diabetes insipidus. A very, very important consequence or mechanism to understand the lack of effect of ADH on the renal tubules. Diabetes insipidus. It's a very interesting medical condition. So please pay attention here. Please pay attention here. So diabetes insipidus can be of two types: central diabetes insipidus and nephrogenic diabetes insipidus. There is another type called as psychogenic polydipsia. I'll discuss that in the end of the topic. So what is central diabetes insipidus? The name itself is suggesting us there is deficiency of ADH because of problem in the hypothalamus. There is decreased level of ADH in the body. Hence, it is not able to act on the renal collecting ducts. It is not able to cause reabsorption of water and urea. Usually, the cause of central diabetes insipidus is autoimmunity, sometimes trauma, sometimes tumors, or very rarely we have genetic or familial basis to explain. All right. Please remember that out of all these causes, all these etiologies, trauma is a transient or temporary etiology. Trauma is a temporary etiology, transient etiology. Sometimes cutting the pituitary stalk can cause diabetes insipidus. All right. And sometimes destruction of the hypothalamus. Hypothalamus destruction can lead to diabetes insipidus. This is also central form. So central form of diabetes insipidus can be because of disease in the pituitary gland or the hypothalamus. Either the pituitary gland or the hypothalamus. So it can be because of hypothalamic disorder or the pituitary disorder. So central diabetes insipidus is absolute ADH deficiency, and this may occur because of hypothalamus disorder or pituitary disorder. Hypothalamic disorders like result from hypoxia, head trauma, infections, CSF related diseases, cancer, or sometimes radiation can cause all these. Whereas pituitary can be because of sudden disease in the pituitary gland, tumor in the pituitary gland, section or cutting the pituitary stalk, cutting the pituitary because of during some neurosurgery or because of trauma. Sudden disruption of this pituitary stalk can result in pituitary necrosis, and this can cause central diabetes insipidus. So when in central diabetes insipidus, what's happening to ADH? There is ADH deficiency. So what should be the treatment? The treatment should be, you should replace ADH. How will you replace ADH? By giving desmopressin. By giving artificial vasopressin, that is the DDAVP, desmopressin, arginine vasopressin, DDAVP. Desmopressin we call it. Alright, let us try to understand the nephrogenic diabetes insipidus now. Nephrogenic diabetes insipidus means here ADH levels are normal, but the kidney is unable to respond to the ADH level. So disorder of the kidney actually. Or if you talk about disorder of the collecting duct. Collecting duct is a tubule, is it not? So tubular disorders. There are different types of diseases of the kidney, like glomerular disorders, we call it glomerulonephritis. Tubular disorders, we call it tubular nephritis or tubulointerstitial disease. So tubular diseases of the kidney. Tubular disease of the kidney. Sometimes for certain drugs which affect the collecting tubule, like lithium. Lithium is a drug which is given in anxiety, which is given in mania, anxiety, mania related states, and this can cause nephrogenic diabetes insipidus. It's a very, very important question. Please remember this point. Sometimes acquired diseases of the collecting duct, sometimes hypokalemia can be associated with this. Hypokalemia and hypercalcemia. Hypercalcemia. Alright, nephrogenic diabetes insipidus, that is the presence of use of lithium or low potassium, high calcium, all these factors cause reduction in ADH action, effectiveness on the target cells. Alright, we have various mechanisms here to understand. I'll discuss this when I'm discussing nephrology chapter in general medicine or internal medicine. I'll discuss this again, but please remember here there are various mechanisms to understand this. But here the important mechanism is to the destruction of aquaporins. I told you aquaporins are important channels which are produced by ADH to reabsorb water. So destruction of aquaporins, aquaporin traffic is affected, and its action on the luminal membrane is affected, that is the collecting duct is affected, and thus it results in nephrogenic diabetes insipidus. Diabetes insipidus means deficiency of ADH. Alright, so let us try to understand what happens to the plasma osmolarity. What happens to the urine osmolarity? What happens to the ADH levels, plasma ADH levels, and effect of drug, that is desmopressin. We'll try to make a tabular column and we'll try to understand all these parameters in various conditions. For example, in a normal person, we'll try to understand. In a person who is suffering from central diabetes insipidus, we'll try to understand. In a person who is suffering from nephrogenic diabetes insipidus, we'll try to understand. Nephrogenic diabetes insipidus, we'll try to understand these parameters. Alright? So in a normal person, the plasma osmolarity is around 297. The urine osmolarity is around 800 to 900. Plasma ADH levels are normally high. Alright, and no effect of desmopressin we'll not talk about. On the urine osmolarity, we'll talk about it later. On urine osmolarity. On urine osmolarity, in normal person we'll not talk about because it is unchanged usually. Unchanged. Urine osmolarity is unchanged. Say suppose a person is suffering from central diabetes insipidus. What will happen to his plasma ADH levels? Plasma ADH levels are low. Plasma ADH levels are decreased. Alright, is it not? So obviously if plasma ADH levels are decreased, what will happen to the urine osmolarity? Because anti-diuresis is no more diuresis occurs, the urine osmolarity is decreased, very much decreased, around 100. From 800 to 900 it has fallen down to 100, so it is decreased. Urine osmolarity also decreased. What will happen to the plasma osmolarity? Because there are various other mechanisms which maintain plasma osmolarity. Plasma osmolarity, in fact, it increases. Plasma osmolarity increases. All right. And after giving desmopressin, the urine osmolarity should increase because there is deficiency of ADH. We are replacing the ADH by giving desmopressin. Desmopressin is nothing but is a synthetic ADH, and that is causing increase in the urine osmolarity post ADH, post desmopressin treatment. After desmopressin treatment. In case of nephrogenic diabetes insipidus, let us try to understand. In case of nephrogenic diabetes insipidus, the plasma ADH levels are high or normal, is it not? They are high. If plasma ADH levels are high and plasma osmolarity is also normal, around slightly increased, if at all it is increased, slightly it is increased. But what will happen to the urine osmolarity? Because the target organ collecting that is aquaporins are not acting on it. Again, the urine osmolarity is low. It is around 108, 106, something like that. But here if you give desmopressin, do you expect any change in the urine osmolarity? Answer is no, there is no change. Or slight change, it may increase to 110 or 118, something like that. So there is no significant change, especially in case of nephrogenic diabetes insipidus, and this is how you differentiate the three diseases. All right. So this is all about diabetes insipidus, which is characterized by deficiency of ADH. Let us talk about hypersecretion of ADH, called as syndrome of inappropriate ADH. Syndrome of inappropriate ADH, excess of ADH, also called as SIADH. Syndrome of inappropriate. So there is excessive ADH secretion. And where is this ADH coming from? Excessive ADH coming because of inappropriate increase in the reabsorption of water, because of inappropriate collecting duct causing increased reabsorption of water. So what is this? What are the important etiologies, or what are the important causes? Let us try to understand. The important cause is, first is ectopic ACTH production, sometimes ectopic ACTH production because of any central nervous system tumor or a lung cancer. Lung cancer sometimes causes ectopic ADH production. Sometimes certain drugs, if you are using antidepressants like SSRI, selective serotonin reuptake inhibitors, or antipsychotic drugs like carbamazepine can cause SIADH. Sometimes disorders of the baroreceptor system, receptor defects, the baroreceptor disorders can also cause SIADH disease. All right, now let us try to understand what are the important physiological aspects of SIADH. Let us try to understand the important physiological aspects of SIADH. All right. So important pathophysiological features of SIADH to note. The first one is there is increased water retention. So in the patient suffering from SIADH, there is unnecessary increased water retention, and patient will have hyponatremia. But patient will be euvolumic clinically. That is, euvolumic means normal volume clinically. Then how do you identify the issue? There is inappropriate concentration of urine, and urine concentration is always greater than plasma concentration. So urine osmolarity very much more than the plasma osmolarity. A patient, especially with hyponatremia, what happens is, in a normal person with hyponatremia, what should happen? Hyponatremia, what should happen is, I told you that it is the sodium levels, plasma sodium levels, which help in detection of osmotic receptors. Osmoreceptors, I told you, osmoreceptors are very sensitive to changes in the plasma osmolarity. And patient with hyponatremia, a normal person should have urine sodium, and the urine sodium levels are low. Is it not? In case of hyponatremia, if I suppose a person has got low sodium levels in the blood, how can you expect more sodium levels in the urine? So in a normal person of hyponatremia, what is expected is, what is expected is the urinary sodium levels are low. But in case of SIADH, it is a disease wherein the urine sodium levels are inappropriately high. Urine osmolality is high. Urine sodium levels are high. This is the diagnosis of SIADH. That is inappropriate secretion of ADH or excessive secretion of ADH, antidiuretic hormone, inappropriately high sodium and urine, especially in case of hyponatremia. So how do you treat this condition? This person should not receive fluids. So treatment is, first important treatment of SIADH. First important treatment is fluid restriction. You restrict the fluids, fluid restriction. Second thing is, there should be no salt restriction, because already suffering from hyponatremia. No salt restriction. Salt restriction should not be done. All right. Some manifestations of neurological symptoms, if at all it is present, you should sometimes supplement sodium. If neurological symptoms are present, hyponatremia, you should treat it. Mild hyponatremia from SIADH can be managed simply by fluid restriction. All right. Nowadays, we have got ADH receptor antagonists, like V2 receptor antagonists. What are these V2 receptor antagonists? Called as conivaptan, tolvaptan, conivaptan. These are V2 receptor. Where are the V2 receptors present? They are present in the kidneys, I told you. They are present in the collecting duct. They stop the effect of ADH into the kidney tubule. Tolvaptan, conivaptans these are the drugs which stop the or inhibit the ADH action onto the tubules, because they completely block the V2 receptors. All right. So what will happen? There is increase in the sodium concentration. Sometimes there is an inappropriate increase in the sodium concentration after using the drug, and that may cause central pontine myelinosis. I'll discuss all these points in internal medicine chapter of endocrinology, definitely. This is just to introduce the diseases associated with increased ADH secretion, called as SIADH, decreased ADH secretion, called as diabetes insipidus. Now let us try to compare diabetes insipidus with SIADH. All right. Let us try to compare diabetes insipidus with SIADH with a person who is suffering from dehydration, with a person who is suffering from polydipsia. That is, some people will have a disorder or disease, psychological disease of taking more and more water, drinking more and more water, called as psychogenic polydipsia, primary polydipsia. They think that they are thirsty. See, if your thirst centers are stimulated because of deficiency of ADH, that is different. But psychogenic polydipsia is, so we'll talk about the various aspects of ECF volume, ECF osmolarity, urine volume, urine osmolarity, then ICF volume, ICF osmolarity. We'll also talk about the permeability of the collecting duct to water, the urine flow, and urine osmolarity. So first we'll discuss ECF osmolarity, then the ECF volume, ICF osmolarity, ICF volume, ICF osmolarity, ICF volume. Hope you are able to understand this. The next, the urine osmolarity, the urine flow, and the collecting duct permeability. The urine osmolarity, the urine flow, and the collecting duct permeability to water. We'll try to understand all this. All right, we'll try to divide this into three important halves about ECF, ICF, and urine. So we'll talk about diabetes insipidus first. Diabetes insipidus. In case of diabetes insipidus, what will happen to the ECF osmolarity? What will happen to the ECF volume? ECF osmolarity is nothing but the sodium concentration, is it not? ECF osmolarity is nothing but the sodium concentration. So in case of diabetes insipidus, what's happening to the ADH? ADH is low. In case of diabetes insipidus, deficiency of ADH. Deficiency of ADH means no antidiuresis. It means promotion of diuresis. Promotion of diuresis means there is increased ECF osmolarity. Increased ECF osmolarity. If osmolarity is increasing, there is exactly opposite occurs to the ECF volume. Exactly opposite occurs to the ECF volume. ECF volume is contracting. In case of diabetes insipidus, ECF volume gets contracted. Alright, when you compare the ECF volume of SiADH and ECF volume of osmolarity of SiADH, exactly opposite is happening, is it not? The ECF osmolarity here is low in SiADH, but the ECF volume is very, very high. ECF volume is, what will happen to the urine osmolarity? Urine osmolarity is high, urine volume is, urine flow is low. We'll talk about this shortly. So diabetes insipidus, ICF on intracellular fluid volume, intracellular fluid osmolarity. Let us try to understand. Intracellular fluid osmolarity is high because ECF is high. Here ICF osmolarity is also high, and exactly opposite occurs to the ICF volume. What will happen to the urine osmolarity? Urine osmolarity in case of diabetes insipidus is low. Urine flow is also low because of urine flow is high, actually high urinary flow. High urinary flow because antidiuresis is absent, so more promotion of diuresis, more and more urine flow will occur, and the collecting duct permeability to water is less because of deficiency of the aquaporins. Deficiency of the aquaporins. All right. Now let us try to compare this with SiADH. Let us try to compare this with SiADH. I already told you that in SiADH there is decrease in the ECF volume, there is decrease in the ECF volume, ECF osmolarity, whereas increase in the ECF volume. There is decrease in the ECF osmolarity, whereas increase in the ECF volume. So what will happen to the ICF osmolarity? ICF osmolarity also low, ICF volume is increased. Exactly opposite is happening with respect to the diabetes insipidus, if you can understand this. But in SiADH, what will happen to the urine osmolarity? Urine osmolarity in case of SiADH is high. Urine sodium is high, urine osmolarity is high, is it not? Urine flow, in case of, because of high osmolarity, the urine flow decreases. And if the urine flow is low, what will happen to the collecting duct permeability? It increases. Collecting duct permeability is high to water. Collecting duct permeability to water is very, very high. In case of dehydration, the ECF volume decreases, is it not? And ECF osmolarity increases, is it not? What will happen to the ICF? ICF volume decreases, ICF osmolarity increases. What will happen to the urine if a person is dehydrated? A person is dehydrated, what will happen to the urinary flow? Urinary flow is low. What will happen to the urinary osmolarity? Urinary osmolarity is increased. So increase of urinary osmolarity and decrease of urine flow, it is seen both in SiADH and also in dehydration. But how to differentiate this? Based on the ECF volume and ECF osmolarity, you should differentiate between dehydration and SiADH. And there is increase in the collecting duct permeability to water. A person who is drinking more and more water, you are calling it as polydipsia, our last case here. So a person who is more and more drinking water, more and more water he is drinking, we call it increase, and just give me a second. I'll try to adjust this document like this. Okay. Yeah. So polydipsia means what? A person is drinking more and more water. If you drink more and more water, what will happen to the ECF volume and ECF osmolarity? ECF osmolarity will decrease, ECF volume will increase. Is it not? What will happen to the ICF osmolarity and ICF osmolarity decrease and ICF volume is increase? Is it not comparable to the diabetes insipidus? Yes. It is. Is it not comparable to the SIADH? Yes. It is comparable to the SIADH. So it is definitely comparable to the SIADH. Is it not? Dehydration, osmolarity. Yes. What will happen to the urine osmolarity in case of polydipsia? Urine osmolarity decreases because the person is drinking more and more water. He'll excrete more and more water. It causes fall in the urinary concentration. So urinary flow, if you talk about urinary flow, is very much increased. If you talk about the collecting duct permeability is decreased. Collecting duct permeability decreased because of increased ADH. All right. So these are all the important differences of the SIADH, diabetes insipidus, dehydration, and the primary polydipsia. This completes the topic of understanding of the posterior pituitary. We have completed hypothalamus, anterior pituitary, and posterior pituitary. In our next class, that is a part 4 of endocrinology. In part 4 of endocrinology, we will be talking about important aspect, that is adrenal cortex. Hope you have understood that class. If you have any doubt, please feel free to contact me over the email ID or phone number or whatever it is. I will be very happy to help you to clear your doubts. Meanwhile, it's an important topic, so you need to revise again and again. Any doubts, please come back to me. Thank you.